We are going to go in order. And Chair has a conflict tonight at 6 o'clock, so the goal is to be out of here by 5 or 5:30. So with that in mind, Senator Merritt, I think I saw you. We'll go in order, beginning with Senate Bill 151. And then there's opportunity for public testimony. Make sure you see Mr. Winning. I'm sure he already made that announcement, but just to double check.
Thank you, Madam Chairman. Members of the committee, it's good to see you all. In this time that we're all working on the issue that is frightening, it's fearful, that of the opioid struggle, the epidemic, heroin prescriptions, pharmacy robberies, you name it. We're experiencing in the state of Indiana. And a part of the comprehensive plan that I put forward this year, we decided that we were going to take a look at inspect, understand inspect, see how we can better inspect. And that's really where Senate Bill 151 and we also put Senate Bill 157 in that bill. And what the summary is it requires inspect to include a checkbox to be marked if a patient has entered into a pain management contract with a designated provider. And I think you probably understand that what we're trying to do is make sure there's one pain contract, and and that's checked, and so we can keep those contracts straight, and so there aren't 3 or 4 or 5 or 15 pain contracts and pain management contracts, so that and many times those pills are sold or stolen. The second thing was from Senate Bill 157, and it creates a working group to study adding the administration of overdose intervention drugs to inspect. A report on the matter will be due December 1st, 2017. It also clarifies that access to inspect data for the Management Performance Hub and Department of Health's state health department epidemiologists. Chronic pain contracts were established back in 2013, but their existence isn't visible in inspect, so doctors don't know what is going on, and that's primarily why we put the box in there. It's just really, really important for us to understand the tool that inspect actually is. In fact, as you probably are all aware, other than Missouri, every state has one, and ours is, I think, 10 years old, and I believe inspect is a tool that is used. Representative Davison, you know much more than I do, but I think it's a good tool, but it can be just made better, and probably is one that is well regarded around the country. But this is one of the answers, I believe. Then when you're dealing with pharmacies, you're dealing with physicians, you're dealing with clients or patients, I just think we need to put a real focus on pain management contracts, as well as trying to make inspect better. And I appreciate you hearing the bill, Madam Chairman. Thank you.
Thank you, Senator Merritt. No one has signed up to oppose this bill, and that's fabulous news. Any questions for Senator? Chairman Brown.
Thank you, Madam Chair. Senator Merritt, I see that the sponsor and co-sponsor of this is Representative Clear and Representative Kirkhofer.
Yes, sir.
You don't know any Democrats over here in the chamber?
I know a tall African-American one.
But I see my...
Representative Porter and Representative Brown and Representative Shackelford and Representative Bauer, would you go on the bill with me? Thank you.
Yeah, I'll be honored, Senator.
I'll go get your tea hot for you.
We will ask the speaker to open it up.
Yes, sir.
Representative Davison?
Yes, thank you, Madam Chairman. Senator Merritt, would you be open to an amendment to add a physician assistant to that working group?
Absolutely. I'll be open. I think the more people that utilize Inspect, that understand Inspect, the better. And I think that's a great addition.
Okay, thank you. Do we have that amendment
Do you-
possibly to put into?
So there, so
Yeah.
there is an amendment
Yes.
prepared. It is in our packets, and I know I saw it. I've already forgotten. Would that be amendment number 3, Representative Davison?
Yes, I think so. I think it's
Would you
number
like to
3.
offer that?
I would like to offer that.
What's the will of the committee? Would you like to accept by consent amendment number 3, which adds physician assistants to the group? We take it by consent. Okay, we now have an amended bill. Any other questions or comments for Senator Merritt?
Thank you.
Do we have a motion?
Move to pass as amended?
Second. So we have an amended Senate Bill 151. Mr. Winning, please call the roll.
Representative Kirkhofer.
Yes.
Representative Bacon.
Yes.
Representative Bauer.
Yes.
Representative Baning.
Excused?
Representative Brown.
Yes.
Representative Davison. Yes. Representative Frizzell. Yes. Representative Leahy. Yes. Representative Porter.
Aye.
Representative Shackelford.
Yes.
Representative Slager.
Excused?
Representative Zint. Representative Zimke.
Passes 11-0. Congratulations, Senator Merritt. We will go to Senate Bill 226. Senator Merritt.
Thank you, Madam Chairman. Senate Bill 226 is the governor's agenda bill, and it's seeking to work on the opioid issue in regards to prescription reform. What this bill does is it limits the prescription of opioids for minors and first-time patients. It clarifies Indiana's statute regarding partial filling of prescriptions and allows rulemaking to determine exceptions to prescribing rules. What we're trying to get to is creating a 7-day opioid prescribing limit for minors and for adults who are receiving their first opioid prescription from the prescriber in question. Now, we have taken into consideration with this legislation, if someone cannot, for instance, if they live an hour and a half away from Annapolis or an hour and a half away from their physician and can't get back to see their physician within the 7 days, the physician has the professional judgment that they may prescribe 3 weeks of opioids if that is what they feel is the best route, or the physician cannot get the client or the patient back into their office because they're too busy. They may, in their professional judgment, and that's an exemption, prescribe 3 weeks or 4 weeks, whatever they decide. The exceptions, along with the professional judgment, are cancer, palliative care, hospice, medication-assisted treatment for substance use disorder, and a condition adopted by the rule of medical licensing board that is deemed necessary to be exempted, along with the professional judgment. And I want to emphasize, professional judgment gives them the flexibility that if a patient cannot travel back to the doctor and see them, the doctor may, the physician may prescribe as much as that patient can. So the 7 days does not come into effect if it's a cancer situation, palliative care, hospice, medication-assisted treatment for substance use disorder. a condition adopted by the rule of the MLB that is deemed necessary to be exempted, or professional judgment. If the prescriber uses palliative care or professional judgment exemption, he or she must document in the patient's medical record. Rulemaking regarding further exemptions will be done in consultation with Department of Health and FSSA. You might have noticed the Indiana State Medical Association and the Indiana Hospital Association wrote a letter to the governor recently volunteering to write guidelines for acute care, day 2 through 89. These individuals also, these associations, were very successful in writing guidelines for emergency department physicians during the Pence Drug Task Force that we traveled around Indiana listening to, and they did a really good job of those guidelines. The partial refills, just an add, partial refills will comply with requirements of the federal code. We're just putting those in line with the federal code. The Senate Bill 226 is a good start. I do believe when we look back on 2016, we will be surprised how many opioids, the amount of opioids that have fallen off from 2015. We aren't there yet, but I do believe that we're making progress with the amount of opioids being prescribed in this state. But this 7 days with the exemptions is a good start for us to get control of the opioid problem in our state in regards to prescriptions. And I appreciate you hearing the bill, Senate Bill 226.
Questions for Senator Merritt? Representative Frizzell.
Good to see you again, Senator Merritt. We started early in the morning, didn't we? So you've been a busy man.
Yeah, thank you.
I had some pushback in the beginning of this bill. As you know, you and I have discussed it. Orthopedic surgeons were concerned about it, especially where they do a lot of research and all, have patients that don't live close to where they would have to get the prescriptions, that type of thing. I think you covered it, I believe, in where you said it's professional judgment.
Yes, I think that is a pretty good carpet.
Of the prescriber. So in other words, if they prescribe, they need a 3-week or 4-week. So I think that covers them. I haven't heard any pushback on them. I don't know if there are some that may still have some angst about it, but I don't know if you know of any at this point.
No, Representative Frizzell, I really appreciate you asking that question. We had pushback on the first half with the Senate deliberation on this bill, but when we've described what the exemptions are, including all these, including professional judgment, all of the concerns had melted away. And I've not heard anything for 2 weeks on this issue. And I can remember how many I heard when we first started out with this bill.
Well, I appreciate it. I don't know if the original bill had some of these exemptions or were added there too by amendment process, but I appreciate you putting that in there. That was a very important language, so thank you.
Thank you.
Chairman Brown.
Thank you, Madam Chair. Senator Merritt, again, I raised the same question. I noticed that both the sponsor and the co-sponsor are both of your liking, and I don't understand why the Senate does not deem it a good concept to have bipartisanship on bills that you send over here to this chamber.
Could I intervene?
Would you help me, Speaker?
Yes, I will. I didn't hear much from Governor Pence, but I had heard from this governor the first few days, and he sent his emissaries to ask me my opinion of this bill, and they asked me to go on it. And I hope he talks to you too, because through him, I said I would.
Good. Representative Brown, we don't have Senator Miller anymore, and we've got to fill some gaps. And so you pointed out a gap. And Representative Davidson will get his pen out, and we will add you to the bill.
Could you pass that word on to your colleagues over there in the Senate that there are Democrats over here, and we, in every endeavor in sending bills to the Senate, try to have
As caucus chairman, I will put a memo out soonest.
That would be very much appreciated.
Thank you very much.
Representative Shackelford.
Thank you, Madam Chairman. I just want to touch on, Representative Frizzell did point out one of my questions that got answered, but I had a question also on the 7-day supply. Yes, sir. What about refills then? Will a person need to get their refills in person, or can they do it over the phone?
They can't do it over, they have to do it over they have to do it in person, not over the phone,
They have to do it in person. Okay, thanks.
person. That's why we were so flexible with the exemption, with the exemptions.
Other questions for Senator? Seeing none, Senator Merritt, there are, I think, 6 individuals that signed up to support 226. And to the extent that you can be brief, since those who would like to testify all support. But Dr. Jerome Adams, that's not Dr. Adams. Of course he can, yes. Mr. McClellan.
Members of the committee, thank you for the opportunity to speak on behalf of Senate Bill 226, and thank you, Representative Kirkhofer and Davison, for carrying this governor's agenda bill and hearing it today. My name is Jim McClellan. I am the Executive Director for Drug Prevention, Treatment, and Enforcement for the state of Indiana. I don't need to tell this group the magnitude of the opioid problem in this state, but it's a problem that cuts, it's in big cities, it's in small towns, it's in rural areas. It cuts across all the socioeconomic lines, and it certainly cuts across political parties as well. There is a complex problem. It's got a lot of pieces. There are no easy answers or quick solutions, but I'm convinced that we can end this epidemic, and we're developing a comprehensive plan to do so. And we do plan to incorporate public health and public safety strategies, expanding treatment, and putting a heavy emphasis on prevention. But we need every tool that we can get, and this bill is one tool that will help us in the battle. You've heard the statistics. Excessive prescribing of opioids is widely acknowledged as one of the most significant reasons this epidemic developed in the first place, and that was not intentional, but it happened. And the consequences have been devastating. In 2015, we had over 20,000 people in this country die as a result of prescription pain reliever overdoses. Compare that with 12,000 deaths that year from heroin overdoses. And we had the 15th highest drug overdose death rate in the country that year. Prescription rates have started coming down, but we do need to do more, and this bill will help. Recent research at Dartmouth-Hitchcock Medical Center in New Hampshire might be instructive for us. Surgeons there found that their patients were consuming only 28% of the opioids that were prescribed. And based on those findings, those surgeons substantially reduced the number of pills they prescribed to prevent long-term use by patients and to help block diversion of the pills for non-medical use. A study of 224 of those patients showed a drop in the number of pills prescribed, averaging 53%. Only one of those 224 came back for a refill. With your permission, I will defer to my colleague, Dr. Adams, Commissioner of the Department of Health, for more details about the importance of this bill. I just want to thank you for your time today and for your support.
Thank you, Mr. McClellan. Dr. Adams.
Madam Chair, thank you. Members of the committee, again, I'm Jerome Adams, and I'm here in your capacity as State Health Commissioner to briefly discuss Senate Bill 226, which I believe would better control how opioids are prescribed in Indiana. I want to thank Senator Merritt, who also happens to be my senator, for proffering this bill, because I think it's an important first step. Attacking the opioid epidemic is one of Governor Holcomb's 5 pillars, and defeating this epidemic will require us to take a comprehensive approach that examines the many factors that have contributed to it. I'm grateful to all of you for considering this bill and considering adding it to our tool chest. One of the biggest contributors to the epidemic is the overprescribing of powerful painkillers. The number of prescriptions for opioid pain relievers has quadrupled since 1999. That alone is a staggering number, but to put it in perspective, I ask that you consider this. The U.S. makes up 5% of the world's population, but consumes 80% of the world's opioid supply. That's the United States. Indiana, as a state, is one of the top prescribing states, prescribing over 1 painkiller prescription per person over 6.5 painkiller prescriptions in Indiana every single year. I was just at an FDA hearing on Monday where we were talking about the opioid epidemic that's going on down in Scott County and the HIV outbreak that we've recently had. And we saw that down there, Opana was being prescribed at over 10 times the expected rate in that community. And that's if you assume that all of it was being prescribed appropriately, which we know it's not. We heard from our deputy, or from our district attorney, Southern District Attorney, earlier today, again at a meeting, and he said that they have drug take-backs, and every 6 months they are taking back 1 to 2 semi-truckloads of opioids from people in the community. 1 to 2 semi-truckloads are being taken back. So again, we have a big overprescribing problem here in Indiana, and it's an alarming statistic for people who use opioids, but not just for people who use opioids. We know that 80% of heroin users started by diverting prescription drugs. Many patients believe they shouldn't feel any pain during treatment and recovery. And physicians who recommend physical therapy and non-opioid pain management, Tylenol and ibuprofen, which, by the way, work great and are better than opioids for most of the types of pain that opioids are being prescribed for, these physicians encounter resistance from patients who want opioids as the quickest solution. These factors have led to a prescribing culture that has made painkillers the easy way out for providers and patients, and has contributed to the opioid epidemic gripping our state. And I said this in the House, in the Senate, and I want to repeat this again. I sincerely apologize to you as a physician on behalf of myself and on behalf of my colleagues who have contributed to this opioid epidemic, and I want to thank the IHA and the ISMA for being partners in supporting this bill. Senate Bill 226 takes an important step by offering a common-sense solution to overprescribing that empowers both prescribers and patients. It's not a magic pill. There is no magic pill for pain management, and not for this opioid epidemic. Mr. Frizzell mentioned earlier that it's going to be difficult, but I have to say to you, it isn't always convenient to save a life, but we have to do the right thing here. This bill gives prescribers a legal leg to stand on when they tell patients they don't need more than a week's worth of painkillers. I was talking to Dr. Virginia Kane, who many of you know just earlier, and she mentioned a patient who sued her for not giving the pain medication that they requested. She called up several of her colleagues, and they found that this patient had been doctor shopping and had been to several other hospitals. So this bill empowers folks, and Dr. Kane asked that I deliver that message to you all, that this is something physicians crave, that prescribers need to help protect them. It also allows patients to take some control of how much they're receiving. For example, this bill allows a patient to fill only a portion of their prescription if they don't think they need the full amount, as Senator Merritt elucidated. That provision creates a safety net for patients who realize the full prescription they've received is excessive or simply unnecessary. And some of you all have heard me tell this story. I've told it in the Senate in Washington, D.C., about how my wife had bottles and bottles of pills left over from her C-sections that she didn't want, but were given to her anyway. How I had bottles and bottles of pills left over from my wisdom teeth being pulled that I didn't want, but that were given to me. And if you want one, you've got to take the other 89 that come with them. And so this bill would allow us in that very real scenario to say, no, I'm only going to get 10. That's all I think I need, and not have those other pills lying around the house. This bill would reduce the amount of unused pills sitting around, and we know that a lot of people who get addicted to opioids start with legally prescribed medications. We heard another story this morning about people who literally go to open houses and go around to people whose houses are for sale just to rummage through their medicine cabinets because they know there are going to be opioids found in them. By allowing doctors and patients to partner and prescribe the right medication, the right amount of medication for the right length of time, we reduce the potential for prescriptions to be aborted, abused, or diverted. So I want to close by saying thank you for considering Senate Bill 226 and for helping Indiana build a comprehensive approach to stopping this epidemic. The work you do won't just change lives, it could save them, and this is not a magic pill, but a very important start. With that, I'd be happy to answer any questions that you have. I know that you're going to get pushback from some providers in the community, but again, I say to you, it isn't always easy to save a life, and this is the right thing to do. I also do want to show you this. This is from the National Governors Association. I was in D.C. and got it from them last week, finding solutions to the prescription opioid and heroin crisis. This is what all governors across the United States are looking at, lest you think we are out on our own here. And one of their main recommendations says that we should limit new opioid prescriptions for acute pain with exceptions for certain patients. Partner with healthcare providers to establish dosage and daily limits for new opioid prescriptions for acute pain, with exceptions for certain patients and flexibility for prescribers to use their clinical judgment in determining when higher doses or longer prescriptions are appropriate. That's exactly what we're striving to do here. It's what's been done in multiple other states, and it's what Governor Holcomb would like for you all to deliver for the people of Indiana.
Well said. Thank you, Dr. Adams. Question for Dr. Adams or Mr. McClellan? Representative Davison.
Yes, thank you, Madam Chairman. Dr. Adams, on the partial fill on controlled substances, well, specifically opiates, now, I'm trying to figure this out, how this is going to work exactly. So let's say I went to the dentist and they gave me 20 hydrocodones. Okay, and I said, I think I only need 10. And so I just get 10, but then I'm still having a dry socket or something after that. Would I be able to go back and get the other 10 under this provision?
Under the federal provisions, which we're
Yeah.
seeking to duplicate,
Right.
that you would still be able to.
You can
You'd
get
be
up
able to
the
go back and get the
quantity
rest.
that was written for originally?
Yes.
Okay, that's what I thought, but I just wanted to verify that. Thank you.
Now, I want to be honest with you, and we're going to lean on you for this, along with the pharmacist folks, and we need to talk to them. We need to make sure that all of the pharmacy chains have systems in place within their computers to account for that, and to make sure folks aren't charged co-pays when they come back for the rest of it, and that it accounts for that. But that is the intention behind the legislation.
Partial fill system.
Exactly.
Yes, thank you.
Other questions? I don't
Thank
see
you,
any.
Madam
Thank
Chair.
you. You're welcome. Thank you.
Did you get your question answered about palliative care?
I think that we have someone who's going to come up and just suggest that maybe down the road MLB would, yes, so.
We'd be
thank
happy
you.
to.
Yes, well, I had a question about palliative care, but Dr. Feldman's going to come and make a recommendation.
Okay.
So, but we're not going to amend the bill.
Okay.
Okay.
Well, and I did want to mention to folks, because I know that's a question that's come up, about whether or not hospice is included in one of the provisions. An important aspect of this bill is there is going to be a rule writing process so that if anything is in doubt, we can clarify it further on down the road. But in Indiana Code 161917-2, for the record, under the definition of palliative care, it says discussing the patient's goals for treatment and treatment options, including hospice care when appropriate. So it is our belief, and I've talked to folks in different agencies, that palliative care as an exception includes hospice care. But if we need to clarify that during the rulemaking process further, we're happy to in addition.
Thank you.
Thank you.
Thank you. If we do that, it's my recommendation that we do it outside of the bill and down the road. Thank you. Dr. McGough, representing State Medical, and Julie Halbig, you are on deck.
Thank you, Madam Chair. Members of the committee, my name is Dr. John McGough, President-elect for the Indiana State Medical Association, representing over 8,500 Hoosier physicians, and I'm here to strongly support Senate Bill 226. I'd like to thank Senator Merritt for bringing this to the floor, and also Senator Houchins for being a co-sponsor in the Senate, and the House side, Representative Kirkhofer and Representative Davison also being sponsors. As you may all be aware, the ISMA does not typically advocate for further regulations on the practice of medicine. However, our members acknowledge their role in this opioid epidemic that Indiana is suffering from and want to be a leader in identifying and implementing tangible solutions. With that said, we are delighted that Governor Holcomb's team sought the insight of the ISMA and other stakeholder groups in working on this legislation. This bill highlights prescriber accountability while still allowing for calculated flexibility in treating patients. It requires a physician or any other prescriber to only prescribe 7 days for a first-time opioid prescription. However, asserting the medical expertise and training that prescribers may consider whether it would be appropriate to prescribe beyond those 7 days if the patient's condition meets any of the enumerated exceptions. Massachusetts has already implemented a very similar provision, and the feedback we received from our counterparts was that this measure is successful. Since its implementation in Massachusetts, it's served as an additional safeguard to ensure responsible prescribing. With the proper education and messaging, we are confident that this measure will also garner positive results here in Indiana. Ultimately, this bill is another tool in a comprehensive approach to combating the opioid epidemic, and the ISMA is dedicated to its implementation. As Senator Merritt said, we're already working with other stakeholders, including the Hospital Association, the State Department of Health, and other partners in acute care guidelines that we'll be working on in the coming months. Thank you, Madam Chair.
Thank you, Dr. McGough. Questions? Thank you so much. Julie Haubig with the Hospital Association, and Dr. Feldman, you are on deck.
Madam Chair, Julie Halbig, representing the Indiana Hospital Association. We too rise in support very strongly of Senate Bill 226. Don't want to repeat testimony, but I will just offer this. The collaboration that has come together with Senator Merritt, Dr. Adams, and the governor's team has been great, along with ISMA, because we all got in a room and approached it from a common sense point of view, specifically the key on adding the professional judgment of a prescriber was critical to all of our support. I think also that this language will institute a whole new conversation that prescribers have with their patients and start changing the dialogue that takes place. And then finally, I think it's going to be incumbent upon all of us at IHA, ISMA, and all the healthcare associations to follow up with appropriate education to all our members, not just on this bill, but all the bills that we're taking forth addressing the opioid epidemic. And with that, happy to answer any questions.
Representative Bacon.
Thank you, Madam Chair. Thank you, Julie, for your testimony. I just want to confirm that one thing we've done this in the past, and one of the things that's come from the Hospital Association, which I've had numerous discussions with, is that by trying to do something like this, you're going to get dinged by your accreditation bodies and CMS and so forth. So are we sure that this is still going to be okay with them, and them not come back and say, okay, now we're going to knock down the accreditation rating of our hospitals because we're doing something we really need to do? But they're still on a federal level telling us that we shouldn't do it. We should be doing better pain management.
Yeah, no, I think, again, with the conversation that's taking place at the national level and the progress that we've seen already in other states that are implementing similar measures, such as Massachusetts, we won't have any issues, but we can obviously go back and double and triple check with them. But I think that's an important thing. But again, based on the national situation and what we've already seen in other states, we should be fine.
Thank you.
Thank you, Julie. Dr. Feldman, I made a special request that you address my question about palliative care versus hospice, and are they complementary, are they same, and could you give us lay people an understanding?
I'm Richard Feldman. I'm a family physician, former state health commissioner. And I also represent the Indiana Academy of Family Physicians. By the way, the Academy is firmly supportive of this legislation. There was some concern in the medical community that the bill did not specifically list hospice. It listed palliative care. And there was just a concern to make sure that that was included. I had a great talk with our state health commissioner yesterday. He explained the previous statute that mentions hospice under palliative care. And that's how the medical community feels about hospice. It's a subset of palliative care. But because the government, CMS, payers treat it differently, a different benefit, different definition, a little bit different definition, that they were just concerned that it was included. Dr. Adams explained that the intent of that previous statute was to include it under palliative care. I thought the language in that statute was a little unclear, but that apparently is the feeling. It's also obviously the intent of our author, Senator Merritt, that is included under palliative care as well. So I don't think there's really a problem. I think the medical community is going to be fine, and if there is an issue that comes up, we can deal with it in the rulemaking process at the Medical Licensing Board.
I appreciate that explanation. Thank you. Questions for Dr. Feldman? Thank you very much. David Bausman, representing the Attorney General's Office, and then Lindsay Moss, you're our final witness.
Thank you, Madam Chair. David Bousman, Legislative Director for the Office of Attorney General. We rise in support of Senate Bill 226. We thank Senator Merritt for authoring it and Madam Chair for being the House sponsor, and also thank Governor Holcomb for having it on his agenda as well. We believe 226 is an important step in limiting the overprescription of opioids and, again, being part of a comprehensive tool in battling the opioid epidemic. Our office has been involved on the chronic pain regulations and doing outreach and education, and our office is happy to help in the process along with the other associations on education and outreach with this bill.
Questions for the Attorney General's office?
Thank you, Madam Chair.
Thank you, David. And Lindsay Moss, representing Accelerate Indiana Municipalities.
Thank you, Madam Chairwoman, members of the committee. My name is Lindsay Moss with AIM, Accelerate Indiana Municipalities. We represent Indiana's 567 cities and towns, and we serve as the official voice for municipal government in Indiana. Thank you to Senator Merritt and Representative Kirkhofer and all the other authors and sponsors of this important legislation, and for all of your work on opioid issues generally. I appreciate the opportunity to be here today to express AIM's support of Senate Bill 226. It may seem a little unusual to see a lobbyist for local government and health committee talking about a bill about prescribing practices, but the opioid crisis and all of the problems addiction brings is impacting cities and towns in every corner of the state. Our mayors and other local elected officials aren't just taking phone calls about trash pickup and when the next snowplow is going to come through. They're getting phone calls from friends and neighbors and residents who are making sure our first responders are carrying Narcan, who are reporting concerns about dirty needles in parks, and those who are desperate to know what local treatment options are available. These are issues our members are going to have to continue grappling with on the back end, but to the extent that we can prevent people from becoming addicted to opioids in the first place, we should. This bill is a great first step on the prevention front, and we encourage your support of this legislation. Thank you.
Questions for Ms. Moss? Seeing none, thank you very much. What's the will of the committee? Any discussion?
Move to pass.
Mr. Winning, please call the roll.
Representative Kirkhofer.
Yes.
Representative Bacon.
Yes.
Representative Bauer.
Yes.
Representative Binning.
Excused.
Representative Brown.
Let's give him a chance to get back to his desk and put him at the end of the list again.
Representative Davison. Yes. Representative Frizzell. Yes. Representative Leahy. Yes. Representative Porter.
We'll put him at the end of the list.
Representative Shackelford. Yes. Representative Slager.
Excused.
Representative Zint.
Yes.
Representative Zemke. Yes. Representative Brown.
Excused.
Representative Porter.
Senator Merritt passes 10-0, and we will ask Speaker's office if we could open this one up for additional authors. Senate Bill 408, Senator Houchins. I said Senator Houchins plural. It's Houchin.
Yes, thank you.
Sorry about that.
Thank you, Madam Chairman, members of the committee. As I was getting ready to come up here, I checked the time and it was 4:08. So, hey. I want to thank, first of all, my co-authors in the Senate, Senator Charbonneau, Senator Merritt, Senator Kreider, Senator Walker, Alting, Head, Breaux, Randolph, and Senator Ford. I also want to thank Representatives Zint and Davison and Bacon for sponsoring this bill in the House. It did pass out of the Senate unanimously, and I'm happy to talk about Senate Bill 408 today, which does work in conjunction with Senator Merritt's Senate Bill 226 to combat the opioid epidemic in our state. As you know, there exists a staggering drug abuse problem in Indiana. A fundamental source of our existing drug abuse problem is the overprescribing of opioids. The CDC has rightly called this prescription drug problem an epidemic. To begin to curb the epidemic, we must meet the problem at its source, the prescription pad. Senate Bill 408 is aimed at combating the overprescribing of opioids in Indiana. When considering this legislation, I ask you to consider a few data points that have been compiled by the CDC. Since 1999, the sale of prescription opioids has quadrupled, and the United States has seen a 500% increase in prescription drug overdoses. There are now nearly 20,000 prescription overdose deaths per year in the United States, making it the leading cause of accidental death. While many prescriptions are used for their intended purposes, many abuse our current system by doctor shopping and filling prescriptions from as many doctors and at as many pharmacies as possible in short amounts of time. In Indiana, doctors prescribe 96 to 143 prescriptions of opioids per 100 persons, making us one of the highest prescribing states in the nation. In 2015, just under 16 million prescriptions for opioids were written in Indiana. That is more than one opioid prescription for every man, woman, and child in the state. And it accounts for 1.15 billion pills inundating our communities. Between January and September of 2016, prescription numbers and doses for opioids were on track to exceed the 2015 numbers. Last March, a doctor in Fort Wayne was determined to have massively overprescribed to thousands of patients over the span of a couple of years, personally contributing to the millions of prescriptions flooding our streets. Just a few weeks ago, a doctor in Miami County was charged with 55 felony counts, including dealing in a controlled substance after it was determined he routinely doled out prescriptions to hundreds of drug addicts per day, with little to no examination or reason for the prescriptions. His actions led directly to at least 2 prescription drug overdoses. And last month, a high school student in Denver, Indiana, was arrested after he was found to be in possession of more than 600 prescription pills at school. He told authorities he had taken the pills from home. These are just some examples of the rampant overprescribing in our state, when individuals can easily obtain hundreds of unnecessary and potentially deadly prescription pills, either due to the doctors who overprescribe and dispense or doctor shopping. And so we have Senate Bill 408, which seeks to help curb the number of drugs inundating the communities. First, Senate Bill 408 will require doctors who wish to prescribe opiates to register with INSPECT, Indiana's prescription drug monitoring program. Currently, only 44% of practitioners in the state are registered with INSPECT, and even less are using it regularly. The Indiana Professional Licensing Agency is working to hope to have 100% registration by the end of the year, but if they're registering for it, we have to be sure that they're also accessing it and using it and doing those searches. So under Senate Bill 408, prior to writing a prescription for opiates, doctors will be required to search INSPECT for a patient's 12-month prescription history and recheck it every 90 days, or after 90 days have expired and a patient comes back again, if that time has elapsed, they'd have to do a recheck. This will enable doctors to make sure patients are not doctor hopping for multiple prescriptions. Certain exceptions for this include administration in a hospital setting, cancer treatment, hospice care, or diagnosis of other terminal illness, or if it's for acute pain following surgery and the supply is for less than 7 days. A search would not be required. I have previously worked for the Department of Child Services. I have seen firsthand the doctor hopping that occurs. And under our current system, the prescription drug monitoring program at the pharmacy level is the data is updated every 24 hours. If, and I have seen families that have left their kids at home for 2 days' time while they travel down I-65 and stop at as many emergency rooms or doctor's offices and pharmacies as they can to get their hands on these prescription pain pills. Currently, if we aren't requiring a search, they have the ability to do that. They can fill as many prescriptions as they can get their hands on as long as they do it within 24 hours. So that brings us to making this as easy as possible on the providers. And $10.9 million is available in federal funds for addressing the opiate crisis. We're required to use 80% of those funds on treatment and addiction services, but we are also able to use an additional 20% in other ways to address this issue. And I'm proposing that the additional funding be used for a grant program administered through the Professional Licensing Agency to fund the integration of INSPECT into the electronic medical records. This bill doesn't require that folks integrate, but it does provide a funding mechanism and for integration should a facility wish to go down that route. The technology is ready, it's available, and it would make a 2 to 5 minute search instantly available to prescribers in the electronic medical record. So we are responsible for solving this drug problem. We can treat the opiate addiction and give every effort we can to that in our state. But until we address this problem at its source, we will continue to deal with greater and greater numbers of addicts, overdoses, and rising healthcare costs. With that, I thank you for your time and attention. I'm happy to answer questions.
Questions for Senator? Representative Davison?
Yes, thank you, Madam Chairman. Senator Houchin, in this bill, it specifies, you mentioned opiates, but it also, in here, it specifies all controlled substances.
Controlled substances. Anybody that has a DEA license.
Well, I mean, yeah, but it says if you prescribe any controlled substances. So there are controlled substances that are actually for epilepsy, seizures, and things like that. I mean, are we going to require the doctor to inspect on everybody that gets a controlled substance, or are we just focusing on the opiates?
Well, it's modeled after similar legislation in Ohio that did do that. And we have that controlled substances database, so inspect includes all of that. So if you're asking for an inspect check, then it would be controlled substances, because you'll have a doctor that might have a doctor might be prescribing a benzodiazepine, and a separate doctor might be prescribing a pain medicine. And so right now, under the current system, those two doctors may not even know that the patient is on both of those very high potency drugs. And so
right. Okay, but what I'm saying is, I guess if a person was prescribing a drug maybe that was used for epilepsy or seizures or some relation like that, would they be required to inspect?
I would be happy to talk with you further about,
just
if
a thought,
that's
because I know there are
something we
some
need to
things
look at.
which could be, once it's integrated, it probably won't be a problem, but just for now anyway, that's what I was thinking. Okay, thank you.
I'm happy to talk to you about that. I also have for each committee member, Madam Chairman, the numbers of prescriptions written and pills dispensed in every county in the state, so you can check your own districts. I know in Washington County alone, it was like 167 pills for every man, woman, and child, 3.5 million. So it's staggering when you look at these numbers, and I'd be happy to pass these out.
Thank you. To Mr. Achenbach here. Other questions for Senator Houchin? Seeing none, we have 7 individuals that have signed up to speak to the bill, 3 in support, and they would be David Bausman, again from the Indiana Attorney General's office.
Thank you, Madam Chair. Again, David Bausman, Office of Attorney General. Keep my testimony brief. Appreciate Senator Houchin for authoring Senate Bill 408. Again, we believe this helps in the monitoring and reporting on the controlled substances, and rise in support of Senate Bill 408.
Thank you so much. Question for Mr. Bausman. Thank you for being here. And I forgot to tell you who's on deck. Dave Powell, Prosecuting Attorney's Counsel, and Julie Haubig will be on deck.
My name is David Powell, Executive Director for the Indiana Prosecuting Attorneys Council, and we support Senate Bill 408 because we believe it will help with controlling the abuse of prescribing opiates and other narcotics. I went this summer, along with Senator Merritt, some others, to the state of Ohio to an event sponsored by the Ohio Supreme Court. I think there were 6 states there, and our Chief Justice asked me to go and others as a part of a team. And one of the things that was pointed out there was that Indiana didn't have a mandatory inspect program. We were one of the few states that did not. And then for those states that did require prescriptions to doctors to check, that they had less of a problem and that it was helpful. So certainly there's evidence out there that this will help reduce the issue. Senate Bill 408 Pat Harrington, prosecutor from Tippecanoe County, testified in the House, and Pat strongly supports this bill. And he told an example in Tippecanoe County where there was a young couple that were abusing this, and when they were finally caught, it was determined they were making up to $90,000 a year getting these pills and selling them in his community of Tippecanoe County. The one thing I would just share is that, you know, the DEA data, and they don't have the 16 data out, but the DEA, Department of Drug Administration data for 2015 is that there are 2 million folks in this country abusing opiates, prescriptions, and another 500,000 abusing heroin. We certainly know that opiate addiction leads to heroin addiction, and you know, I want to commend the Indiana General Assembly on behalf of law enforcement that this bill, and of course 226 earlier, all of these bills that you're considering to reduce and control the overprescribing of opiates are a good thing. And I believe they will have a positive impact on reducing that in Indiana, but we also know that people with opiate addiction will not just stop using. And so I would say that while restricting these pills being prescribed, given the level of addiction, we will certainly see increased demand for the use of heroin. And as a result, that's a negative consequence from good legislation. And so we would urge you to consider that, and as we go forward, looking at the drug dealing penalties for heroin, those certainly merit attention as well. And we will certainly continue to advocate for that. But we support this bill and bills like it.
Questions for Attorney Powell? I see none. Thank you. Julie Howbig, Hospital Association, and Dr. Roscom, you are on deck.
Julie Halbig, representing the Indiana Hospital Association. IHA rises in support of the direction that the bill keeps moving. As we shared with Senator Houchin back in late January, we stand in support of the goal of complete integration of the INSPEC database with the electronic health record systems within the state and in our hospitals. Our main concerns that we had in last January are still present, which is we just are concerned about the cost of integration and how quickly that can happen before the mandatory query portion of the bill goes into effect. I do think the amendments that were added in the Senate helped with that. Senator Houchin put in language that allowed for regular updates from the pharmacy board to monitor the progress of both the integration and the application of the federal dollars that will hopefully help fund some of this. I think these updates will be critical in deciding if the July 1st, 2018 date that you see in the bill as it relates to the mandatory query may need to be pushed back. And then one other thing I did want to let you know is currently there's a pilot being conducted down at Deaconess Hospital in Evansville. This pilot is going to be very helpful in our learning experience and working out the kinks as with any IT project on, you know, what worked, what needs to work better as we try and get this more integrated throughout hospital systems and health systems and the EHRs. So we'll continue to work closely with the administration, especially the pharmacy board, on monitoring that pilot, and are happy to help give the respective health committees updates on how that's going. But I think that'll be key to letting us know what the timeline is and how quickly we can keep working on this. Happy to answer any questions.
Questions for Ms. Halbig? Thank you. Dr. Ruscom, Franciscan Alliance, Nicole Van Andel, you are on deck.
Thank you, Madam Chair, committee members. I'm here to comment on several provisions of Senate Bill 408 relating to the health information technology integration with INSPEC and also the provider use mandate. So on the issue of the health information technology integration with INSPEC, the report that's mandated for the end of the year, in the interest of time, I did provide my comments in writing to you, so I'll just get to the pertinence. My suggestion is that provision be moved to December 1st of 2018, simply because by the end of this year, there will only be 2 pilots conducted in Indiana with integration, one with the hospital system that was previously mentioned, and one with the pharmacy chain. So it's hard to imagine that report's going to provide a lot of insight about some of the either benefits or challenges that providers are going to face in the state regarding integration. On the topic of the provider use mandates, I'm here advocating that the mandate on prescribers to use Inspect with a manual login without EMR integration be removed from the bill. I think the more effective approach for the state is to use that grant money and also have the Inspect agency lead the state in getting prescribers to connect their electronic record systems with the Inspect program, because it resolves a lot of the workflow issues that are going to result if, under the current bill, you simply mandate people log in and check a database, or they do it every 90 days. And so in my written submission, I've indicated a number of reasons why I think that that's not a good solution at this point, and I think all of the effort should be to promote the use of electronic integration, which is what you see in states like Ohio, where they've mandated that solution. And so I'd like to thank the committee and the chair for my being available today, and I'll take any questions folks have.
Questions for Dr. Roscom. Dr. Zent.
So you feel that we need another year on this to integrate this better and follow up on some studies that are going on right now? Is that the
Well, I think the easiest solution is to just mandate people do things, but there is a technology available. And by the way, I think the idea that the technology is just simply available is not true. With the pilot that's going on in Evansville, for example, the vendor is going to have to write the interface from scratch. So it's not like you can just turn it on. But I think there's a great deal of promise today, since most prescribers either use an electronic health record system or e-prescribing system. They can automatically query the Inspect database when they're connected and resolve a lot of the workflows. So you can have workflows where, as you're writing a prescription, the system will query and check for you and bring back the history. What that does is remove all of the manual processes out of these. And we know that Inspect's been around for 10 years. We don't have 100% adoption of it by prescribers. When you look at the actual usage, the number of logins is actually quite low. So obviously, in my opinion, being someone that works in the area of health information technology, applying technology that basically addresses some of these issues about why people don't do these kind of workflows, I think is very important. And certainly, we're about at the point where we can do this, but it is going to require concerted effort to do that. And for our organization in particular, we already have a proposal on the table to integrate our electronic record system with Inspect. Up until just recently, that wasn't allowed. And in fact, technically you can't do it today until they finish their pilots. So we are going to make that commitment because we think that's a workflow enhancement that benefits everybody. And we're going to spend a lot of money doing that. The annual fee to us for this service, because remember there's an ongoing subscription cost if you're a prescriber, will be in the range of $200,000 to $300,000 a year. But as an organization, we are willing to pay that to make a workflow that actually works. Thank you for your question.
Dr. Zinn, are you considering coming out of retirement?
Not at those costs.
Thank you. Any Representative Shackelford?
Thank you, Madam Chairwoman. When are the pilots expected to be completed?
The information I was given was that they are a little soft at this point, but there's a pilot with a major pharmacy chain that's either starting up or sort of in process, and there's, as mentioned, the one in southern Indiana. There's no exact date for those yet. So my comment related to the report is I think the report's not going to have a lot of useful information in it because it really won't show at scale what this effort's going to take across the state. It's going to show you possibly that 2 organizations were able to do this. And I think we need a lot more experience for that report. So I would just suggest that it be delayed for a year.
Okay, thank you.
Thank you, Dr. Roscom. Nicole Van Andel, I hope I'm pronouncing that properly. You are a representative of Indiana Health Information Management Association. And Dr. Feldman, you're on deck.
Madam Chairwoman, thank you for the opportunity to speak today. I am representing the Indiana Health Information Management Association. Health information management professionals safeguard health information in various care settings, working to ensure patient safety and privacy is protected through quality information in medical records. In order to do this, processes must be in place to ensure the proper matching of patients to their specific healthcare information and electronic health records. Accurate and reliable patient matching continues to serve as a barrier to a successful nationwide information exchange and is foundational to the successful linking of patient records within care delivery sites and is a building block for interoperability and health information exchange. Standardization is also needed at the source of the data because all healthcare organizations have different patient naming conventions, use different methods for identifying duplicate patient records in their own systems, and may have multiple records for a patient within their own EHR system. Over half of health information management professionals routinely work to mitigate these duplicates. When all EHR systems capture and store patient demographic elements in the same format, algorithms will be able to match patient records consistently within and across healthcare organizations. Without accurate patient matching, providers may have incomplete information on their patients or may be presented with inaccurate information. Patient matching errors often begin during the registration process and can generate a cascade of errors. The InSpec report contains sensitive information. If incorrectly attached to a patient record, it could cause safety issues and could limit the treatment a patient deserves. It can also lead to privacy breaches. In order to share information, it must reduce the data integrity issues first and develop an information and governance program. Based upon the information presented above, it is IHMA's belief that the mandate would be very concerning from a privacy and security standpoint and could jeopardize patient safety and the quality of care. We also recommend that the Indiana representatives work with U.S. congressional leaders to promote the need for a national patient identifier, and we also recommend that standards for data collection and error corrections be consistent among all healthcare providers. If you have any questions, I will be happy to answer them.
Thank you. Any questions for Nicole? Thank you so much.
Thank you.
Dr. Feldman, you are on deck, and then Mike Brady, you will wrap it up.
Richard Feldman, representing the Indiana Academy of Family Physicians. We have some real concerns about the way this bill is written and the components. We don't disagree with the spirit of the legislation and the purpose of the legislation. But the way it's written now, it's going to be, if it's enacted, it's going to take effect. And there's never a guarantee or a link in the language to the integration of the electronic medical record with InSpec. And the concern of family docs, if this never happens, it's going to be in effect. And manually opening up and searching InSpec takes about 5 minutes. We have 10-minute slots. And can you imagine the practice life of a family doc who has to do this, and we're going to get way, way, way behind. Because we have such a short time nowadays to see patients. And this isn't just opioids, it's all controlled substances. And there are a lot of controlled substances that we use legitimately with legitimate patients. So this is really, we want to be part of the solution, but this is really burdensome. And even if there was successful integration, I also represent many, many family docs working in rural communities. We all don't work in Indianapolis, and they have paper charts. Many of them have paper charts, and this is going to be nearly impossible for them to get through the practice day. So that's our concern. Thank you, Madam Chair. Thank you for the opportunity to speak.
You're welcome. Any questions for Dr. Feldman? Speaker Brower?
If you limit this bill to opioids, would that be helpful?
Would that be what?
It's open to drugs. If you limit it to opiates, would that be helpful?
Yeah, I don't want to stand up here and try to fix the bill, but you would be right. That would be certainly a help. But also the frequency of having to search inspect is another issue. So yeah, I think there's some things that could be done, but I'm not prepared to fix the bill.
Dr. Zent?
Yes, thank you, Dr. Feldman. We're all interested in, as a former provider, 245 days retired. Yes, and counting. I understand that, but you know, the other side of the coin is that this is a huge problem. You'd be willing to work whatever way we can to make this agreeable. I can understand if you've got 6 10-minute slots in an hour, and now all of a sudden you're 15 minutes because of the 5 extra minutes. You're seeing 4 instead of 6. You multiply by that by 8. I go broke. I mean, honestly, it's a concern. I can see that. I can see that. But the other side of the coin is the good that we can do.
Absolutely, and we want to be part of the solution. And the Academy of Family Physicians is always willing to sit down when we're invited to try to make things better.
Thank you.
All right, Mike Brady representing State Medical.
Thank you, Chairwoman, members of the committee. I'm Mike Brady with the Indiana State Medical Association, here on behalf of over 8,500 Hoosier physicians. I should also note that I am the most recent director of the INSPECT program, so I have an intimate knowledge of the program, its capabilities, as well as its current initiatives. So with that said, the ISMA opposes this bill as we're concerned with various provisions in it. Most notably, this bill is a mandate on practitioners, as you've all heard already, that they must check for every controlled substance that's being prescribed. This will be costly and have a negative impact on the access to care, as you already heard from Dr. Feldman. There's time slots for each patient, and when I went around the state for the past year and a half and I spoke with providers all over, one of the major concerns I heard across the board was that how long it took and how cumbersome the system was to use as it is today. I hear usually 5 minutes and up is how long it takes. And you can imagine, you know, in your smaller rural community physicians' offices, how much that can be compounded as well. Right now, for a provider to access the program, they have to go through the state-run web portal, which is, again, the cumbersome part of that. But the good news is we're going to actually have the integration initiative that you already heard about, which is going to be taking place. We already have today a format for that that's been approved by both the Board of Pharmacy, the Governor's Drug Task Force, as well as various other stakeholders in this, that use the program. You may have already heard, and we've already mentioned twice today, that Ohio already has a system in place, and that is true. What Ohio did a couple years ago is they mandated use of INSPECT through integration, but the state also said they would fully fund it across the state. So that was great, but also what happened was they implemented both of those immediately. So when they did the first audit of this, because integration didn't fully take effect across the state, they did the first audit, there were 12,000 physicians in Ohio out of compliance with the law because integration did not fully catch up. That's something we may want to keep in mind. But as we worked on the pilot, and I believe Deaconess Hospital right now is in the process of doing that, and I believe others are teed up to work on this as well, we're going to be closely monitoring it. And I think the second provision we need to look at is the mandatory registration provision. The good news, again, is that the state is working to do that. They're updating the platform software, and that should be coming this April. However, it may not roll out right away. So this bill goes into effect July 1st, or that provision does at least. Then there are going to be providers out of compliance again, even if they register the manual method of doing so on the back end for the program is very cumbersome again, and maybe months before they are able to process each of those registrations. So that's a concern that we have to worry about as, again, practitioners will be out of compliance. But the automated process is going to be great. It's going to be tied into the the licensure process. So once a provider is approved for their state CSR and their federal DEA number, the program will automatically send them a notification saying you're now registered to use the Inspect program. Here's how you log in for the first time. So that should be coming soon. My concern is that if we do this and there's any hiccups in that process, we're going to push back that feature, and it's going to cause further problems. And again, practitioners may be out of compliance. So there's no cushion built into this bill as it is right now. And then finally, something I'd like to briefly touch on is there are various federal grants that are out there right now. But as I'm sure you are all aware, grants come with many strings attached. And my concern would be that with these strings that are attached, and there's a lot of them for the ones we already have in the program, the concern would be that it would hamper the operations of the program team. And so that's something we also have to be cognizant of. So with that, I'm happy to take any questions.
Representative Frizzell.
Madam Chair, thank you. Mike, thank you for your testimony, and I can some of your concerns. This is more of a process question than what you have to say and the validity of thereof, which I'm sure is good. But were you guys aware of this when it was in the Senate, when it was going through? Because I'm looking at the vote tally. It was 49-0.
Yes,
wait, let me finish. Excuse me. I always find this interesting because I get, when I have a bill that's important to me, I have no testimony against it, and then all of a sudden it goes to the other house and the floods come in, right? And I'm not angry about it, but I just want to know what happens. Because if this is this important, I would think that those who are objecting to the bill right now, that they would have said something early in the process, which would have given us more time to deal with issues that they were concerned about.
So I would like to answer that first. Representative Frizzell, you probably didn't know, but in the world that I live in, I'm very aware of sharing health information, and I also reach out to stakeholders when I schedule a bill for hearing, and began asking them questions that they weren't able to answer to my satisfaction. So I felt it is a well-intentioned bill. I think it needs some more work. I'll let you answer the question, but I was the one that started having the conversations that led us to where we are today.
You're just because you're an outstanding chairperson, that's why, right?
That could be.
Thank you, Mike.
Yeah, please, go ahead.
Yeah, I was going to say, we were aware of the bill. I had just actually came back to the State Medical Association, so I was kind of playing a little bit of catch up as there were various bills that were out there we were working on. We did have colleagues that were working on the bill that were keeping me in the loop.
Representative Davison.
Yes, thank you, Madam Chairman. Mr. Brady, you say there could be problems trying to roll this all out by July 1st of 2018, right?
Yes.
For everybody to be in compliance. Mm-hmm. So I was just thinking, what if there was a way that we could say, as this rolls out, the people that are that it's available to fall under the statute, but you're not out of compliance until you have that availability to you. So if a hospital has not got it in their system yet, or electronic records, it's not electronic medical records, if it's not available to them at this point, maybe they wouldn't have to be included at that point so they'd be out of compliance. But anybody that has that ability at that point, as we're rolling this out into the Inspect program, we could do it that way maybe. Is that a thought? Would that be something that you would be?
Definitely something to consider. We'd have to see what that looks like. As we have, my concern again would be the smaller private individual practitioners. So if that would include them as well, where they're, like Dr. Feldman said, may only have paper charts, that would definitely be something to consider.
Right, so how could we address that with those folks? I mean, we'd still like them to use Inspect, but they may not have, I know some docs that don't have access to electronic medical records, and they're still using the paper charts, just like Dr. Feldman said. So what would you propose that we do with the folks like that maybe are not going to get electronic medical records? I mean, some just may not want to do it, period. So how do we appease that?
I do not have an answer for that today.
Okay, because it seems like there ought to be some method that we could say, you really need to use Inspect, but
in the old-fashioned way of using it's always going to be available through the web portal.
Right.
But We know there's practitioners out there that don't even have broadband still, so that is something to consider.
Okay, thank you.
I think a great compromise would be to find a way to help healthcare providers who want to opt in, but not mandate those that can't. So, thank you. I saw some hands, and then it looks like Dr. Feldman wants to take another bite at the apple. But Representative Shackelford.
Thank you, Madam Chair. Mr. Brady, with your experience and with what's going on with Inspect Now and with the pilots, what date would you recommend that we actually implement this program?
So that's kind of what the pilot was for, is to figure out where the speed bumps are, where are the hurdles, and then we can better evaluate that later on. And I actually have a copy of the Inspect Integration Initiative for all the members of the committee to take a look at to see how we plan on rolling this out. Well, not me anymore, but the agency plans on rolling this out. Once we get a green light from the pilot, we want a measured rollout of this, just again, so it's not going to interfere with the practice of medicine.
Then, when do you?
Since I have left the agency, I do not know what the latest conversations have been, so I'm not sure what that is.
Thank you. Representative Zent.
Yes, Mr. Brady, Mike. So a concern you have is, well, we saw what happened when electronic records first came out. I know a number of individuals said, I'm not doing it, and they sayonara. The compliance is probably going to be a problem right now. As Senator Houchin said, only 44% are even signed up, and less than half of those are utilizing it. That's kind of the issue you're dealing with here, but also there's not everybody's going to require a controlled substance, so a lot of your patients who won't need to look it up. In my own practice, I rarely wrote for that type of pain medication. I can see others in the same venue. So you're saying that everything is kind of in motion and we're trying to fit the pieces together.
Exactly.
But we also have a crisis now, and I think that's the reason for the emphasis. So hopefully, probably just making a statement, we can move quicker instead of slower.
Yeah, I agree.
Dr. Feldman for closing argument.
Thank you, Madam Chair. I just didn't want to fix the bill here in front of us, but you know, we could have a different implementation date, but we could also have different criteria and requirements for those who don't have an electronic medical record. And I just want to point out to Representative Frizzell, I gave the same testimony in the Senate. So someone spoke up. Someone spoke up.
Thank you. Thank you. Well, Senator and Representative, it looks like you have a little work to do, so we'll hold this today and continue. If you'd like to, sure, yes. And so to finish, we'll hold this today and see if they can bring it to a spot where we can have all stakeholders in agreement.
Thank you, Madam Chairman, for the opportunity to close and offer some of my thoughts after hearing some of the testimony. I will tell you that Mr. Feldman was the only person to testify in opposition to the bill in the Senate. We did not hear from Mike Brady or the Medical Association when this bill was presented in committee. And I will say this. I met with Mike Brady when he was with the Professional Licensing Agency about this bill last fall. So there has been knowledge of this concept and what I was trying to achieve. And Representative Zent is absolutely right when he says only 44% who are writing prescriptions for controlled substances are registered with Inspect, and less than half of those are searching it before they write a prescription for controlled substances. People are dying every couple of days in Marion County of an overdose. Statewide, we are having a very extreme epidemic of prescription drug overdoses and abuse. And so that is what this bill is designed to do. It is designed, A, to encourage integration, which we've heard testimony on today that everybody is in agreement. We want to have integration. So it's encouraging that by providing a funding mechanism, asking FSSA to seek out grants that are already there and apply for grants that are waiting for the application to fund programs such as this in the state of Indiana to address this concern. But in addition to that, I would ask, how much are we paying for Inspect in the first place to only have 44% of practitioners using it? We should have everybody who's wanting to write a prescription for opiates, controlled substances, they should be searching those records. Inspect is a login to a database, and there's no cost to access Inspect. There is cost to integration, which makes it a 5-minute search, a 5-second search, which we all want to get to. But this is a problem that, quite frankly, I saw the numbers from my own district and statewide, and I was appalled that we have this problem going on. And I would ask, similar to what Dr. Adams asked, is how much time is required to save a life, to stop a problem before it starts. So I would certainly appreciate your support for this legislation, which passed unanimously out of the Senate. I'm happy to work with Representative Davison on trying to fine-tune some of those things. I did make changes to the bill in committee at the suggestion of the Hospital Association, which was to review the progress of integration by the end of this year, see how those pilot programs are going. So we have a review. And then we delayed implementation specifically to July of 2018, so we would have the next legislative session to further address this issue if we need to come back and extend that window if it's not going as well as we hope it will. So, but the idea that we would just do nothing right now is not acceptable. So I really appreciate your time in hearing testimony.
Madam Chair, can I just ask her one question?
Yes, sir.
I'm drawing a conclusion that if 44% know the history of a patient before they prescribe these drugs, does that mean 56% don't know the history of some of these patients, and then they go ahead and prescribe these drugs? Is that what the
Well, it's actually less than that, Representative Bauer, because 44% are registered with Inspect. Less than half of that are checking the database regularly. So the vast majority of those that are writing prescriptions for opiates are not registered with Inspect, and more than half of those aren't searching it, and they're writing prescriptions for controlled substances.
Then I agree with you. There's some urgency in getting something done.
Thank you.
I'm going to, ladies first, Representative Zimke.
Senator, I'd like to thank you for bringing this bill forward. Indiana is number 9 in the most opiate prescriptions written in the 50 states. And I'm really tired of Indiana rating so high on such really horrible lists. So I certainly hope that we can prioritize this and find a way to make this happen. We need to use every tool we have.
That's right.
And granted, I don't know the nuts and bolts as much since I don't work in a medical office, but I certainly believe that we need to prioritize everything that we can. So I certainly hope that we will consider it. So thank you for bringing it forward.
Thank you.
Representative Davison.
Yeah. Thank you, Madam Chairman. Senator Houchin, would you think that maybe if we did say that at the date that you have in here in place, which I'd like to keep that date, that anybody that's in the system, but there may be some hospitals and some doctors that's in the system that aren't rolled out yet, that we could go ahead and start at that date with the folks that are in place, and then maybe as we progress through the process, that add those other folks in.
Yeah, I'm happy to talk
would
about
something like that be
to try
agreeable
to have
you?
a specific rollout process, so we don't have to delay people
Right.
even further if they already have
Rather than
access.
just delaying the whole thing, at least we said
Yes.
the ones that are started, we could go ahead and work with, and then kind of roll it out as we go.
That's correct. I will say this, and I'm certainly in agreement of that, but I don't want to also let the perfect be the enemy of the good. So
Right.
I don't want to do nothing while we're
Exactly.
waiting to
That's-
get there. And, there are, and I wish that someone would have asked Mike Brady, and I have asked, how many physicians' offices don't have broadband? I haven't gotten that answer. And also, how many are on paper records? I haven't gotten that answer. And so it would be helpful for me to know that, to get that information, and I have asked the Medical Association to provide it. But then we would know exactly what we're dealing with instead of trying to, for us to speculate that it is a huge number when it may not be that large a number at all. It might be a few, and we could maybe make an exception for those few. But even if it takes a 5-minute search to go out of, if it's not integrated, to me, that's not too much to ask to solve this problem.
Right. And, you know, possibly the folks that don't have broadband or that have paper records, we could limit theirs to just opiates.
Right.
And give them less.
We want to make it certainly as
Right.
painless as possible, which is why I put the funding for the integration piece in the bill.
Okay, well, thank you.
Thank you.
Representative Bacon, since you also have a very rural district, and I saw you shaking your head with the broadband issue, would you join Representatives Zent and Davison in seeing if you can convene a stakeholders meeting and see what we can do to get a good bill?
Be happy to.
Thank you. Seeing no other comments, thank you so much.
Thank you.
Representative Davison, will you be presenting Senate Bill 51 or Senator Grooms? It will be you? Okay. I had previously set aside 15 minutes for this bill. I will give it 30 minutes now, 15 minutes to each side. But we absolutely must conclude by 5:30. I have to check with the bill sponsor whether we will be voting on this today. I think so too. And I think I counted, it's been a while now, 13 or 14 people who have signed up to testify. So I think there's a misunderstanding in your bill's language. So would you please present your bill?
Right. Thank you, Madam Chairman. And thank you, committee members, for hearing Senate Bill 51. It comes over to us from Senator Grooms. This is basically a bill that, first of all, I'd like to explain. It's a bill that it isn't a requirement. It's not a mandate for anybody. Currently, pharmacies are allowed to do immunizations through the pharmacy. They've been doing the influenza. They've been doing shingles. They have several others that they also do. And what this is doing is currently just allowing people, it improves access for folks to be able to go to your pharmacy and get those immunizations when you need them at your convenience as you desire. So basically what this bill is doing is it's adding 5 other immunizations that can be added to the current pharmacist immunization physician protocol for ages 11 and over only. And these would include MMR, which is measles, mumps, and rubella, varicella, hepatitis A, hepatitis B, and Hib, or Haemophilus influenza type B. Now, you know, pharmacists have a very extensive training in immunizations, so they become sort of experts in giving these immunizations and have done a lot of them over the past few years, been very successful with shingles and influenza. With Indiana's health ratings, it's important that we expand our access to these immunizations to prevent many of these costly diseases, of course. So this legislation would follow the same procedures that's already in place. We have a physician protocol, a notification of protocol, a notification of the protocol physician and the patient's physician within 14 days, receive consent of the patient or parent or guardian. Immunization data must be entered into the immunization registry, which is called CHIRP. And also we have to have the name, license, and contact info of the physician writing the protocol, and it must be posted, and a copy of the protocol must be available to the individual. And that's pretty much what this bill does. We did have an amendment that we kind of came together with the ISMA and some of the doc organizations, and Mr. Winning has that sort of put together there if we want to. I beg your pardon? Well, actually, I have a couple of amendments to go with this, but I think we just put one together that would actually change something, which, yeah, the one we just talked about at the beginning.
I have an amendment 1 and 2, and then there's a 3 coming.
Right. And
Okay.
we have a 3 that we just talked about that we kind of came to an agreement with the physician groups on, which would actually allow, I guess, you want to talk about it, Steve, or you want me to discuss?
You can talk about the
Okay.
concept, and I'll talk.
Basically, right now, currently, pharmacies, each pharmacy or group of pharmacies gets their own physician to write a protocol. So we have several different physicians writing protocols across the state. Well, what we would like to do when we discuss with the docs is to have the
state health commissioner write a standard protocol across the whole state for the upcoming immunizations and have a standardized protocol that all pharmacies across the state follow. And that's kind of what we would want to do. We would have that take effect approximately a year, I guess it would be a year from July 1st, which would be July 1st of 2018. And in that time, we could have the protocols could be that we pass on this legislation, if we pass this legislation, could also be utilized as they are right now until that time, grandfathered in. So that's basically what the amendment would do, I believe. Am I correct? Okay.
So the
So this would
language?
be a verbal amendment. Basically, we would take House Bill 1540, which was the pharmacy bill that passed out of here, and we would take section number 3 and amend it to say that the state health commissioner shall issue a protocol for the immunizations and may issue protocols for smoking cessation products, and that those protocols would be effective July 1 of 2018. We would also take section 11 out of that bill, which deals with the posting of protocols by the Board of Pharmacy. And then we would also amend section 13, which has the language that allows a pharmacist to proceed under the state protocols. And we would also put an expiration date on the provision that deals with physician-issued protocols. And the only thing I would have to do a search on is to see if there's another section of code out there that deals with physician protocols. It would also have to be expired on July 1st, 2018. So basically, on that date, the statewide protocols by the state health commissioner would take effect and supersede any physician-issued protocols.
We wouldn't be using the smoking cessation language, though, right? Did you say include that?
Well, that would be a May provision, because that was in 20.
Oh, in the bill the way it is?
Yeah,
Okay.
that was in 1540. So
Okay.
we could take that out if you wanted.
Oh,
Then you would
okay.
have
Okay.
two bills in conflict.
Okay,
so-
I was confused what you said. Okay, thank you.
So, Mr. Winning, that was a lot. Would you repeat that one more time? I'm sorry, but I want to make
Okay.
sure I understand.
So we would basically take the latest version of House Bill 1540, starting with section 3, which basically deals with the state health commissioner. It's basically right now a may issue state protocol. So we'd make that a shall for the immunizations, and that would become effective, those protocols would become effective on July 1st, 2018.
And Representative Davison, was 1540 your House bill?
Mhm.
Okay.
Yes, it was.
That was the pharmacy law bill.
Okay.
There is a section or a piece of that that deals with smoking cessation products,
Mhm.
and we would make that piece a may provision.
May provision.
Because currently both of those are mays in 1540. Also in 1540, there's section 11, which requires the Board of Pharmacy to post any protocols that are issued by the state health commissioner. So we would take that section and bring it over. And then section 13 of the bill has a section that basically gives the pharmacist the authority to act under those protocols. We'd bring that over. And then the section that deals with physician protocols, we would have that expire on July 1st, 2018. And as I said, since I got this late, I wasn't able to do a complete search.
Yeah.
But there may be another section of law out there that gives the physicians the authority to issue those protocols. So if there is one, I would also make that expire on July 1st, 2018.
Representative Davison, has this been vetted with the stakeholders, the state medical, Dr. Adams, Board of Health?
Right. I've talked to Dr. Adams. The state medical brought it to me. They kind of were interested in doing it, and we just conferred with one of the chains as well. So, yeah, I think everybody's on board.
Okay. Representative Bacon.
Thank you, Madam Chair. Amendment. This would not give the State Board of any ability to change any of the immunizations, just the protocols on how to do the ones we already have in effect. Is that correct, Mr. Winning?
Yeah, currently, under House Bill 1540, we basically require it to be one of the approved
The approved CDC recommended, I think.
so the CDC but you have to be, I believe, over 11.
11 and over, yeah.
Yeah, not less than 11 years of age, so it wouldn't be the young children under the protocol. And under big section 13, which is, if you look in section 51, or in Senate Bill 51, that's the same code site that we're dealing with here. That's the same list of immunizations, it's just written out here. So that would be the only immunizations that would be allowed under
Be
the
the same
protocol.
ones we're adding here.
Yeah.
Then we would add it to 10 to 1540.
Right.
Correct. Okay, and that was it. Okay, that's what I was thinking.
I don't see a representative from State Medical here.
Back there, there.
Oh, do you have anything to add, State Medical? I mean, my concern is it sounds appropriate, but I certainly want to have your buy-in.
Yeah, that sounded very complicated. Scott Gardeman, Director of Health Policy, State Medical. Basically, what we were looking for was standardized protocols written by the commissioner on the existing list of immunizations that were there. And this is actually a change. We opposed this bill in committee in the Senate, and this is our compromise to make this fit. What we want is that the health commissioner will be the one writing these protocols to make sure they're standardized across the state to be followed by all the pharmacists, so that we can have more access points.
And it would be shall for...
It'd be shall for those
these-
immunizations. So I think there's 6 new immunizations, and the other one, and there's 5 old ones. The 5 new ones, and then the older ones that are included on the same list, but it's that code
And
set.
may for smoking cessation
Yes.
products.
Yes.
Does American Academy of Family Physicians have a position?
No, we like the original bill. We're strongly supportive. We feel our pharmacists are our partners in immunization, as well as long as it's adolescents and above. So 11 and above, we have no problem. Early childhood, we'd have a problem. So we've always been in favor of this. I was part of the discussion on the amendment, and I think it's a wonderful idea. As a former public health official, I know that the Department of Health has a wonderful resource in their division of immunization. So they can create the protocols, and it's really going to be uniform. It's going to be a much stronger situation. I do want to ask a couple questions. I'm a little confused. One, you stated protocols, but it's standing order and protocols. And the other thing is, does this amendment include smoking cessation or not?
That was in the other bill.
Right, but we weren't going to put it in this one.
No, it's not actually in this bill, but it's.
Okay, I just wanted to make
taking
sure.
the language that we had in the previous.
Yeah, but leave the other part of that out. It's just
The
about
reason I was
safety.
going to take that over and put it in the May provision is because we're basically creating a conflict between 2 moving bills, and so I was going to try to get them as close together as possible so that when, so that we don't have a conflict between 1540 and this
So-
one, because 1540 currently allows a May provision for the state health commissioner to issue a standing order protocol for smoking cessation products.
I think Dr. Feldman's going to agree with me from the Academy of Family Physicians. We are fine with the commissioner as a shall for these immunizations. The smoking cessation piece is a concern to both of us, so we would prefer that not be included. That wasn't that was not the intent of our suggested amendment.
We're discussing that for the 1540 across the hall.
So I'm going to make an executive decision. I know it's not going to be a popular one, but I want to get the language right to make sure that we're assured. So we will come up with a written amendment for next time for amend and vote. We believe you, and I know the intent is there, but we want your bill to be successful. So let's make sure we...
Okay, thank you.
So, so we've heard that. Are you going to offer 1 and 2 as well? So let's hear 1 and 2. Let's have the discussion on the bill, and then we will do amend and vote only
Next
whenever
time.
we, yes.
Okay. Okay.
We'll listen to the amendments,
The two that I have
and
prepared.
then we'll discuss,
So,
we'll have an amended bill, so I guess not. Let's just discuss the amendment, the
Okay.
intent of your
Yeah.
bill.
okay, Senate Bill 51, Amendment Number 2. All we're doing is changing the pneumonia from 65 to 50, and that was done in 1540, so we're just trying to make that consistent with the language that was in that other bill. Senate Bill 51, wait a minute, where's the other amendment?
Got a motion on the first?
Oh, I was just describing it.
On Speaker Bauer, on the discussion that we had, I felt it was too complicated. We want to get there, but I would rather LSA come out with something in writing as amendment number 3 so that there's no ambiguity.
Yeah.
And then you just discussed amendment number 2, and now you're on to number 1.
Amendment number 1 allows an entity to reach out to the State Department of Health to mail out mailers to the folks that maybe need booster shots and things, just as reminders. And so that Medicaid already does that, but some of the private insurers, health insurers, don't do that. So this is just allowing a group to be able to reach out and get some of that information to follow up on those types of things
you.
with those.
Thank you.
Which is just a good reminder to make sure that you get your second and third booster for certain immunizations. So that's what that does.
Okay. Several people did sign up to support this, but we're pushing the time allotted for that. I've got a couple minutes left. If any of you are interested in coming up and just saying me too, those people are Dr. DeRoca from State Medical, Dr. Feldman, I presume you'll wave, you're done. I know that Heather Woolley wanted to support this bill with respect to CVS, her client, Grant Monahan, and then the Indiana Pharmacists Alliance, Randy Hitchens. So any of you want to come up quickly? Dr. DeRoca defers and says State Medical is in support. Grant Monahan of, is it Indiana Retail Council? Yes.
Thank you, Madam Chairman, members of the committee. I'm Grant Monahan with the Indiana Retail Council. We've long supported the expansion of the ability for pharmacists to provide immunizations. We continue to hold that position and support the bill with the amendment. Thank you.
Thank you, Mr. Monahan. Mr. Hitchens from the Pharmacists Alliance.
Good afternoon. I am Randy Hitchens with the Indiana Pharmacists Association. We support this bill and have from its inception with Senator Grooms and then Steve Davison's work here today. Again, we're concerned about these deaths that occur during the course of the year. If you look on the back page of the handout, you'll see all the states in green here. Again, we're simply following CDC-approved guidelines here, taking Indiana from 7 immunizations to 12. As you see the map on the back of the handout, this is in nearly most of the states currently at 12 immunizations. So nothing here too exotic. One thing I wanted to point out is that this is not involving doing immunizations on people under age 11. Okay, so we're simply expanding out here to the from 7 to 12 bills. But the Indiana Pharmacists Association does support this bill.
Well, that was quick and to the point. Thank you. And then I have a number of people signed up who do not, and I would like to respect the time of those that travel the farthest. I am going to, some put their cities, some put the mileage, and then others I can tell by phone number. So you have 15 minutes. I would like to remind you that this only, oh, I'm sorry, Representative Bacon.
Thank you, Madam Chair. Have we taken the amendments, the 2 amendments, are we taking those by consent? And then doing number 3 later?
So
the first 2?
That's a very good point. So
So-
Representative Bacon said, can we take the first 2 by consent? And then we'll wait for the amendment number 3, yes. Well, I'm getting guidance from LSA that it's probably better to hold them all
That's fine. I
three.
just wanted to be sure where we were. Thank you.
Okay, thank you. I want to make sure that you understand you're talking about the testimony only on one of the three amendments. Representative Porter? We're not, no. I have guidance from LSA that we should do them all three together in our amend and vote committee meeting. Representative Porter?
Thank you, Madam Chairwoman. So what I hear you saying, and I just want to be correct, is that we're going to hear the bill as it is not amended and then come back and hear it again as amended.
No.
With people,
There would not be another-
traveling, so they have to come back.
We're going to take their testimony today.
But it's amended. I mean, if you don't amend it, we're not speaking to the bill. To the end results of said bill.
Give me 30 seconds and I'll confer with LSA to see what's the best mechanism. Thank you. So would you be, Representative Porter, would you be satisfied with having those that are opposed testify only to the three proposed amendments? I would ask your...
I'm just trying to make this clear for people who don't understand. Make sure the process is working for the public. If we don't amend it today and come back and amend it later, the individuals who are here, and it happens in Ways and Means all the time, okay, they will be testifying on a bill that is what it is right now, not necessarily betting on the proposed amendment. So they will have to come back and vote and come back and testify for the other three amendments that we have. So they have to come in twice. And I was just trying not to let that happen for them who travel, the citizen legislature.
You make a good point. However, they're not afforded the ability to come in and testify on second reading amendments either. So that's the process. But what we can do is let them testify onto the bill as it stands, which is adding the new vaccines and to the three amendments that we'll consider next week. And then that's the world of, it's the bill and the three amendments. So the universe is the bill, which was adding those 5 vaccines to current law, and then the 3 amendments that we brought up. And then that's the universe of what we've discussed today. Alicia Burkhart from Ingalls, Indiana, and then Autumn Chittum, who traveled 30 miles. And what's the will of the committee? Would you like me to, there are, looks like maybe about 10 or so. Would you like me to limit them to a minute apiece, or what's your recommendation?
How long do I get to talk to you on this?
1, 2, 3, 4, 5, 6, 7, 8, 9. There are about 9 or 10 people that have signed up. Do you feel a minute is appropriate, 2 minutes? I'm going to ask for your respect in this committee, ma'am.
Say 5 minutes?
Okay.
Madam Chair.
Representative Frizzell.
About the length of time, but in deference to them and their travel, I would suggest no more than 2 to 3 minutes.
2 to 3 minutes, yes. Okay, that's fair. We will do that, and I know that you're sensitive to this, Representative Porter, because I think, do you have a constituent here? Okay. You're right. No, thank you. I agree, but I want to make sure we stay on point. So, Mr. Achenbach, if you will time for 3 minutes.
Oh, sorry. I wasn't planning on being first, and so I'll just describe what I'm here to talk about. It's not necessarily the 5 vaccines being added. It's the lower part of the bill, page 2, probably line 40. I don't have it right in front of me, where it talks about not needing parental consent for vaccination during a time when the government deems a time of emergency. And then there's no request, no requirement for parental consent at that point. And so this is my message on that point. On behalf of the citizens of the great state of Indiana, I come before you because SB51 violates federal and state constitutional provisions. Therefore, this bill should be withdrawn. Before you today is a bill which may seem benign to you. It addresses in part the state's use of its police powers to control during periods of martial law, disease, through vaccinating children without parental consent. According to the CDC, and I quote, "A vaccine, like any medicine, could cause a serious reaction." Quote from the CDC, "A small risk exists for vaccines to cause serious harm or death." Quote from the CDC, "Vaccines are capable of causing serious problems." Quote from the CDC, "No vaccine is 100% safe or 100% effective." You might remember the scandalous news in 2007 when an educational crisis and a public health crisis was declared in Maryland when the parents of more than 2,300 students would not consent to immunizations and students were banned from school. As the state's attorney general said, "We can do this the easy way or the hard way, but it's got to get done. I'm willing to move forward with legal action." Parents faced fines of $50 a day and up to 10 days in jail, and children faced being vaccinated in a courthouse. This shameful story is not an American one. It is a dark history soon to become our own, again, unless you amend this bill. Right outside this building is a plaque warning that Indiana's prior eugenics law, once forced upon Hoosiers, forced sterilization because the government deemed it was for the greater good. This is an example of the socialist and utilitarian powers our government is so ill-equipped and unfit to take upon itself. My desire is that you make an informed choice, make no mistake. Your choice today or whenever is between either giving authority over the bodies of our unique children with distinct medical needs and biological frailties to a distant executive agency, or respecting that authority is our state and federal constitutional right under the First and 14th Amendment and the state's protection of worship and conscience. Your choice today, or whenever, is between government's changing utilitarian definition of the greater good and the concepts of liberty that our country was founded on. On behalf of hundreds of concerned and level-headed parents in this state, I beg you to honor your oath to the Constitution, choose well, and know that your choice will be reported to your constituents and throughout history. You have been, this is a question for you, to your conscience. Have you been convinced beyond a shadow of a doubt that such an infringement on parents' and children's constitutional rights is legally justified
Ms.
under...
Brooker, you're over 3 minutes, so if you'd kindly
I'll just finish my
close.
sentence.
Thank you.
So, I'll start over. Have you been convinced beyond a shadow of a doubt that such an infringement on parents' and children's constitutional right is legally justified under a strict scrutiny analysis under constitutional law? If not, then you must amend this bill. What does it mean to have custody of our children if, at the government's word, they can decide to perform an unwanted medical procedure?
Thank you. I wanted to remind you that the language that you talked about is not up for debate today. We're not talking about that part. That's not being changed.
That's current law that's been in place for several years. That is just listed because it's in the law that
It's the current law.
amending.
We're only...
It has nothing to do with the law we're addressing today.
So the genesis of the bill is adding 5 vaccines to the list of already allowed vaccines. So that's what your testimony needs to be about, or the 3 amendments. So just for clarification, Autumn Chittum, please, and then Autumn Stockton. Autumn Chittum, 30 miles, Autumn Stockton, 25 miles.
Thank you, Madam Chair and committee members. I'm Autumn, and my son is Lyle. I have the same request of the same amendment, which I'm a little confused about because I thought that part was also up for debate. I mean, I guess I'm here. I drove here. I want to tell my story, but my son Lyle turned 3 in November. He received 1 vaccine as a newborn, the hepatitis B vaccine. He developed a high fever within hours of the vaccine that resulted in the on-call doctor at my local hospital directing us to the children's hospital. He developed a head-to-toe rash that a doctor confirmed was an allergic reaction. A rash is described as a moderate to severe reaction to the hepatitis B vaccine per the insert. I decided to wait until he was 2 to give any more vaccines so that his immune system was further developed. 1 month after his 2nd birthday, my son's lymph nodes popped up on his neck. They were the size of walnuts. The doctors were not sure why. We did rounds of antibiotics to no avail. 3 months later, no answers. We started running blood tests, not cancer, thankfully, but low immunoglobulins. He was diagnosed with immune deficiency disorder, and he has compound heterozygous MTHFR, which is the inability to detox properly, along with IgG food allergies. Over the course of the next year, he developed anaphylaxis to all foods high in natural chemicals like glutamate, amines, and salicylates, which basically means my son cannot tolerate most fruits and vegetables, and unfortunately, he cannot have chocolate. His diet is limited to around 10 foods between his food allergies and the high chemical anaphylaxis issue. We carry an EpiPen wherever we go because new foods seem to trigger him that we end up needing to add to the list. I live a type of fear no parent should live, not knowing what can trigger my son into anaphylaxis. I suffer a similar issue along with being diagnosed with 2 autoimmune diseases, rheumatoid arthritis and Sjogren's disease. My 3 stepchildren, ages 17 and the twins 15, have had the same issues with vaccines. They're Lyle's half-siblings. All 3 with IEPs, 1 with Asperger's, 2 with developmental delays, including gross motor and speech, and 2 with documented vaccine reactions from the meningitis vaccine, including vomiting and seizures and blacking out. All 3 children suffered seizures post-vaccinations as children, and 1 child had issues with uncontrollable bowel movements until he was 7. So based on our medical history alone, we are not good candidates for any vaccine for any reason, ever, even if there is a so-called declared emergency. So unfortunately, that's not what today is about. That's pretty upsetting because that's my life and that's what I have to do.
Thank you, Anna, for being respectful. I appreciate you sharing your story. If it makes it helpful, if you all have the Senate Bill 51, those words are in bold that are added to the bill. So anything that is standard type is already current law. And then as you page through it, like on page 1, there are 6 vaccines already allowed by law, and then we're proposing to add 7, 8, 9, 10, and 11. That's all the bill does.
Okay.
And then the amendments that you heard described. So
what type of amendment or what type of wording, what type of rights do I have as a parent to protect my child who is not a candidate for a medical exemption, but under some declared emergency, what is he supposed to do? What am I supposed to do? Who's at fault for that? Who's going to take care of it? Not the people writing this bill.
So I don't know who takes care of it. I'm not a physician. You're right. This bill does not contemplate that. So you could reach out to your legislator and see if next session that there's something that they would bring forth to a health committee, either in the Senate or the House, to propose language that you would like to see. That's our jobs as legislators. And fortunately or unfortunately, we're only talking about those vaccines that we've listed today. So that's where the confusion was, not being difficult, but
Right.
but that language is not up for discussion.
Right.
So, but thank you for
giving me
sharing
the
your story.
opportunity to chat.
You're welcome. Autumn Stockton, and then Janet Gernand. I couldn't tell, but your area code looks like you might have traveled far. So if you'll be on deck over here in this corner, I'd appreciate it. Ms.
Hi there.
Stockton.
Thank you for your time. I also thought that we were able to talk about amending preserving parental consent, so I'm going to pass the mic on to the next person.
Oh, that's nice. Thank you.
Thank you.
Janet Gernand and Chelsea Smith.
Thank you. I, too, was confused on the language, and I was also wanting an amendment to having parental consent. So with that said, I
Thank you. We did have some calls to the State House, and we tried to clarify for those folks that called in and expressed that they wanted to testify that, this is not about amending the law. It was about adding those vaccines to what the current statute automatically allows. So I don't know if you had any, Representative Davison. I know that I did, and my legislative assistant who's sitting in front of me did his best to clarify that. So I'm sorry if that word didn't get to you.
Okay.
But thank you for coming. Where did you come from?
Muncie.
Muncie. Thank you very much.
Okay, thank you.
And Chelsea Smith, and then Jennifer Gallagher. You'll be on deck.
Stop. Part of mine kind of goes in tie with what everybody else has said, but I'm going to go ahead and oppose adding anything that my kid could get in the state of emergency and oppose whatever 7 vaccines are being added to the schedule. I'll start with, my name is Chelsea Smith, and my husband, Staff Sergeant Corey Smith, has served for the last 11 years fighting in both Iraq and Afghanistan for a combined 27 months for your freedoms to be preserved. As a military wife, nurse, mother, and resident of Indianapolis, I'd like to voice my strong opposition to SB51 as it is currently written, adding any vaccines to the current schedule. And I'd like to draw your attention to a reasonable compromise. Please amend page 2, line 40 of SB 51 to say, quote, and C, parentheses 5, unparentheses, end quote. The aforementioned amendment seeks to protect parental consent in a declared emergency when parental consent is of utmost importance. The suggested amendment will not impact the intention of this bill. The proposed changes offer a win-win for parental consent and for the bill to achieve its intended purposes. Dismissal of this amendment infringes upon a parent's fundamental right to consent to medical care for their minor child. Furthermore, it places the child in danger, as neither the pharmacist administering the vaccine nor the minor child knows their individual medical history. With a vaccine injury rate close to 3%, we can expect that 3,000 out of every 100,000 children force vaccinated will become injured during said emergencies, some mildly, some severely. The risk of injury cannot be denied. With over $1 billion being paid through the Vaccine Injury Compensation Program, statistics speak for themselves. Such statistics make me question, does the state of Indiana plan to compensate the families of those injured following said vaccines administered without parental consent? If not, who? Who will be responsible for the medical bills if my child is injured? I will. Who will be responsible for caring for my child if she is injured? I will. That being said, wouldn't you think that I would be responsible for making said decision regarding when and if my child receives said vaccinations? Children do not have the mental capacity to understand the complex nature of vaccines in regards to their immune systems, while pharmacists and the government lack the personal connection and the love for these children that only a parent or guardian can truly understand. We as parents are responsible for feeding, clothing, loving, and caring for our children in every aspect. It is our responsibility to truly know our children on every level, and we are therefore tasked with difficult decisions every day. Without that connection, how can you truly know what's best for another human being? Decisions about how we want to maintain their physical, mental, emotional, and spiritual health should remain the responsibility of those that take the time to truly know these children. It was asked of the Senate to make the amendment, and our requests were ignored. As a parent, I wonder why the Senate refused such a simple request. What would be the reason behind denying parents' rights? Parental consent to medical treatment of any kind is paramount. Use your influence to make this right. It's what the parents of Indiana want. Don't add any more vaccines to the schedule.
Thank you.
There's my kid in pink.
Jennifer Gallagher, and then Carrie Bundy, you are on deck.
Thanks for the opportunity to speak. I'm just curious, can a legislator add this language to this bill to make all of these parents happy as far as clarifying parental consent?
So that's a good point. Yes, amendments can be offered by anyone on the committee. So, of course, they would need to work with Representative Davison. I don't see him. to see if that would be, if he would have the appetite for that. But
Okay, and
yes,
who
yep.
would we ask about that?
I'm not going to have a confrontational discussion with him on the floor, but if you would like to, afterwards, after we've adjourned for the day, perhaps approach, is your legislator on the health committee? Do you know who?
No.
Okay.
No. So I think I'm going to leave it at that. I think I understand what this, a little bit more about this bill
Okay.
now, and I think that would be the next best step for us to take. So thank you.
And you are Jennifer Gallagher. Thank you. Carrie Bundy.
Hi, I'm Carrie Bundy. I've been a lifelong citizen of Indiana. I have 4 children, and I'm pregnant with my 5th. This is my 3rd child. His ashes are in this urn. He was killed after his routine 4-month vaccinations. His health history was otherwise unremarkable. His autopsy was also unremarkable. There was no cause. When I first read this bill, I was also under the impression that we could talk about parental consent because pharmacists don't have my child's health history, and my child might not know their health history, and so would other people's children. They may not know this. As we went down the list of the vaccines, I can tell you that Hib and Hep B were 2 of the vaccines my son received before he died, and the biggest concern that I have is who's going to be held liable when these forced vaccines are given to children and their child dies? Because the vaccine manufacturers can't be held liable. You're certainly not going to be liable. Nobody in this room is going to be held liable. Who's going to be held liable?
Thank you, Carrie. Melissa Surfa, and then Lucy Brinton, you will wrap up.
Thank you for hearing us today. No, we did not believe that there was a misunderstanding at all. We thought that we could come in here and get a current law amended by getting this bill amended. We believe that we could preserve parental consent in declared emergencies if we would just amend line number 40 on page 2. But I am speaking with Representative Shackelford, and there may be something that is already there that we are not seeing, but that remains to be seen. So we are going on record. We are asking for an amendment to page number 2, line number 40. Please add and C5 to protect parental consent at all times, especially in a declared emergency. Again, pharmacists are not aware of patient history, neither are minor children, even 11-year-olds. And so that is what we are basically demanding. I do not understand, and I would like someone to answer for me why we couldn't get this amendment here and at the same time amend what many parents believe is a current bad law that does not preserve parental consent in declared emergencies. So that is my question. Why can we not get that amendment for that? My second problem that I have with the amendment that you discussed with standing orders that are authorized by Dr. Adams, who's an anesthesiologist, who on January 18th spoke to vaccine injured children in the gallery and threatened or offered to go get vaccines out of his trunk to give them their flu shots. When you asked for their private health information, you asked them if they washed their hands and if they had their flu shot. And when they shook their heads no, Dr. Adams said, well, he could go get the vaccines out of his trunk. This is not a blasé or funny issue for any of us. Proper handling and storage of vaccines is a thing. That's the commissioner of our health department maybe joking that he's got vaccines in his trunk. But we don't think that's funny at all. And the vaccine issue isn't blasé. And you can laugh and chuckle, but this is being live streamed and you're all being watched worldwide. And while we may have only showed up in 15, we are not alone. And we are not going away. And we will fight for our parental rights in this state and worldwide and globally for as long as it takes.
Thank you,
so,
Melissa. That's been
thank
3
you
minutes. Thank
very
you.
much.
Lucy?
Thank you, Madam Chairwoman. My name is Lucy Brenton. I am currently a candidate for United States Senate, and I'll be running against Joe Donnelly in 2018. Previously, I ran against Todd Young and Evan Bayh. I think they might have beat me because I only had $3,000 and they had $45 million. Which brings me to my point. Where did the money come from for my opponents? And where does the money come from for bills like this? So when I look at the language of Senate Bill 51 and the proposed amendments, specifically that we want to add the measles, mumps, and rubella vaccination, the varicella, hepatitis A, hepatitis B, and Haemophilus influenza type B, the HIB. I vehemently oppose the addition of any vaccines, especially on the basis of principle, that pharmacists simply don't have access to complete medical information and should not be injecting anyone without the physician's consent and, of course, knowledge and the parents. But that's not the real issue here. The real issue is where is this money coming from? We're going to mandate additional vaccines at a cost to taxpayers. Who is going to get the windfall from those vaccines? Probably the very people who are your cash donors. Probably Merck. Merck manufactures the MMR vaccine. Should we be rewarding Merck with additional contracts and the additional purchase of products by Indiana taxpayers that are known to harm? In fact, Dr. William Thompson, who recently came forward as a whistleblower from the Center for Disease Control, admitted scientific fraud in the landmark paper that allegedly exonerated that very vaccine, MMR, as a cause of autism. We now know, because of the documentary Vaxxed, that indeed the MMR vaccine does cause autism. Please explain to me why we would want to add that to the schedule, why we'd want to add the products of Merck, who killed tens of thousands of people and hundreds of thousands of people were injured through Vioxx. Why are we rewarding that company with Indiana taxpayer dollars? I think it's a very simple issue. We need to look at the money. I think each representative, mine included, and if I'm a United States Senator in 2018, I will proudly wear a jacket that bears no corporate emblems, because I won't take any corporate money, but I challenge each of you to start wearing your corporate emblems on your jacket. We're a NASCAR state, after all. Thank you.
Thank you, Lucy. Representative Davison to give
Can
final.
Can I explain something just a second? This is not a mandate for any of those immunizations. It's simply providing an access if a person wants to volunteer, if they are catching up on an immunization that they haven't had before.
That's not the language of Senate Bill 51.
Yes, it is the language.
The language of Senate Bill 51, as I read it, specifically leaves out C5, which ensures parental consent and presence if a vaccine is administered.
It does have parental consent for all the ones that are administered through the pharmacy. It's in the bill. It's part of the
Well,
protocol.
I would challenge you. Who pays you?
This
Have
is-
you ever
this came from
given a
CDC.
speech for Merck? Have you ever given a speech
No.
for Merck?
No.
Will you get a financial benefit as a result of this?
No.
Have you ever received any honorarium for speaking for Merck or any
Madam
other pharmaceutical
Chairwoman,
company?
I-
He brought it up.
Would you like
He
me
wanted
to
to
limit
ask me
the
questions.
testimony now?
Respectfully, can we get some order? Thank you.
Thank you.
If you're going to ask me questions, I have the right to ask yours. You first, and then I'll go second.
Ma'am, this is not appropriate.
Madam Chairman, I move that we adjourn.
Do I have a second? We are adjourned.
There you go.